All right, hello everybody. Today we're going to be doing a PENG block as well as a left IJ ultrasound image. So initially, I'm going to show you my notes. Those are my notes back there. So initially, you would want to look over the patient's chart. Why are they here? This particular patient had a fall and they suffered a left hip fracture, so they're going to get an ORIF. This is going to be an analgesic block to kind of deter or decrease the amount of opioids required after. So the 50-year-old patient with no medical history truly, and so all the laboratories look normal, all my coags look normal. So after that, I would introduce myself to the patient. I would get two patient identifiers, their name, their date of birth, verify any allergies, which they deny. I would go through their body systems, head to toe. Neurologically, they're intact, lungs, heart, their auscultation is normal. Any kind of liver or kidney problems, they deny that. Any kind of endocrine problems, they also deny that. So right now, the biggest issue with the patient is their lack of mobility. They're having a really hard time kind of turning in bed, difficult with repositioning. And so this PENG block will be covering the femoral, as well as the obturator and accessory obturator articular branches. And so this will be motor sparing. They will pretty much only be sensory, so that'll really help them just with the pain rather than them losing that strength and not being able to do physical therapy here in the next couple of days. So after that, I would explain why, and so I want to do RBI. So some of the risks include nerve puncture, kind of paresthesias, neuropathies. Bleeding is a big one. Like I said, coags are normal, and infection. But this will all be done in a sterile technique, so we're going to try our best to minimize all of that. Some of the indications, like I said, are the left hip arthroplasty that he's going to need, the ORIF, sorry. And so additionally, we've covered our RBI there. So now we would transition and we would get the consent. The patient has consented to get regional rather than being exposed to all those other risk factors with opioids. Some of the opioids could cause constipation, falls, nausea, longer hospital stays, so they're choosing to go with regional. And so after that, we would gather all of our equipment, including ultrasound with ultrasound cover, Stimulex needle with the nerve stimulator, all of our PPE. We would get the appropriate cleaning supplies, the proper draping supplies, proper probes that we're going to be using. We're going to be using a curved probe for the PENG block and a linear probe for the left IJ visualization. So we'd also have the patient connected to all our monitors, making sure we have SpO2, end-tidal CO2, blood pressure cuff, and EKG. We'd also want to make sure that we've done an airway assessment just in the event that we were to need to intubate the patient. This patient is Mallampati 1, no signs of any difficult airways. So we have the appropriate supplies, we have them on the monitor, and so we would be able to proceed. Consent's been signed, so we should be good. We also want to go ahead and have a couple peripherals. We're going to pre-medicate the patient with about 50 mics of fentanyl and about 2 cc's of 2 milligrams of Versed, just to kind of help with anxiolysis and help with pain management. So after that, we're going to go ahead and grab our probe, and then we're going to go ahead and place it over over the patient's iliac crest here. So we have the AIIS, anterior inferior iliac spine, and then we also have the curvature of the bone here. We want to make sure we can locate the femoral artery. Femoral artery is pulsating here, and then you have the femoral nerve just lateral to that. And then here we have the AIIS, the iliopsoas muscle, and then you have the psoas tendon right here over the pubic ramus. So what you want to do is you want to do an in-plane approach. You want to go from lateral to medial, and then you want to hit bone. After you hit bone, you want to walk off the bone and just advance it just slightly underneath and hydrodissect. Aspirate 1 to 2 cc's. You want to hydrodissect with about 1 to 2 of sterile saline, and the psoas tendon will start to come off that pubic eminence, pubic ramus, and so you want to inject about 15 to 20 cc's of 0.25% bupivacaine, making sure to aspirate about every 5 cc's in between, that you're not in the blood vessel. And you should see the hydrodissection of the tendon coming off, and then you should also see the iliopsoas muscle kind of also hydrodissecting. And the way you would test for this is you could place an ice pack on the leg, compare that to the leg that's not anesthetized, and they shouldn't be able to feel that cold sensation on the leg that we anesthetized, as well as they should have preserved quadricep function, so they should be able to bend the knee, they should be able to flex their quads, and that should be the main way to kind of test, making sure that we do have a proper block, and their pain should significantly decrease from, they would report maybe like a 10 and they would come down to maybe like a 2, so it would help a lot. So they would be ready for post-op pain coverage in that aspect. So after we've done that, we're gonna go ahead and show you guys the left IJ. So I'm gonna switch the probe here. I have out of plane view here, and I'm sliding cephalad, and I can see the tip of the sternocleidomastoid, and just below that, if I compress this, that's actually the carotid artery. So there we see the carotid artery, and then I'm compressing the IJ, and then if I let go of the pressure, I can see the IJ, as well as sternocleidomastoid just appeared to that. So typically we would go out of plane, cephalad to caudate with our needle approach for IJ placement. And then once we've gotten blood return and we've been able to advance our wire, we want to make sure that our wire is still in the vessel. And so what you want to do is you just want to rotate your probe. And now we have visualization of your carotid beating there inferiorly. The IJ is in the middle of the screen there, which we can compress. See that? And then the sternocleidomastoid is just going to be superior to that. Again, carotid, IJ, and sternocleidomastoid superior to that, and it's compressible. All right. Thank you very much for that.